Anyway, guys, listen, welcome, everybody. Welcome to Arch. You guys are, you guys are in for amazing 2 cases this morning, 3 cases, and today we're going to have a very, very interesting case. And I have here with me Nate Frogge, he's our interventional fellow. PRASHANTH Thakkar, he's our interventional fellow. Dr. Howard KURZ, you guys know, needs no introduction. And next to me is my very, very good friend here, Dr. David RIZIK, who needs no introduction. And we have Maddie, who's our nurse, and then Dale is our tech, and then Mark, Alexandra, Nicholas are running the show in the control room. So welcome everybody. I'll pass it over to Nate, who's going to present the case, and then we'll get going.
Good morning, everybody. So our patient is a 62-year-old woman who came with classic typical angina. She had chest pain and also radiated to her jaw with pretty low workloads of exertion at class 3 symptoms. She has a lot of classic risk factors: hypertension, hyperlipidemia. She does have breast cancer, but no chest radiation. She's on 2 guideline-directed medical therapies for anti-anginals. Does smoke and has a family history of early coronary artery disease. So she underwent diagnostic angiography. Next slide, please. As you can see, there's already a little bit of hardware in the way, so some of the angulation is a little difficult here. But you can see that she has a right coronary artery that is relatively calcified, severe stenosis or moderately severe stenosis of the mid to proximal RCA there. Next slide, please. And sort of a little difficult to see these pictures because they're off mag, but she has a severe lesion of her prox LAD with some noting in the diagnostic films of dampening of the catheter with engagement. So a question of how far that proximal lesion extends back. Next slide, please. You can see another cranial projection to give you a little bit better sense that it really is mostly isolated, that proximal portion, not too much in the mid to distal LAD. Next slide, please.
Yeah, broke it up. Yeah.
And it's a little bit of an ectopic, sort of a upgoing left main. So you have a really short runway to work with if we're going to be doing the LAD here. Next slide. Okay, that's it. Sorry. Okay, so that's it. We've already started here with getting pictures and done a little bit of work, and Dr. Singh is going to talk with Dr. RIZIK about what we've done so far.
Well, what stands out to me, first of all, excellent presentation, really great job. And I always love being in the WashU lab. These guys are pros. Their staff are seasoned professionals. Howard and Jazz. The thing that stands out about the case is probably the right coronary artery. By invasive imaging may not seem as critical as perhaps some of the functional assessment that you guys performed. I love the functional assessment that you did in addition to invasive imaging. Jazz and Howard teach that. We've had some of their fellows come out and join us, and they're extraordinarily well trained on all of the adjunctive imaging and physiology. And then the other thing that stands out about the case, obviously there's the osteo-LAD lesion, but the lesion in the left main, or the appearance of the left main, looks like there may be diffuse disease, there may be shaft disease. So you may be dealing with left main, osteo-LAD, and right coronary artery disease. And I think this is a superb demonstration case.
Yeah, I'll tell you, if you look at the left system, we think osteo-LAD is involved. We think left main may be involved because the guide is actually bigger than the left main. And you can see LAD and circ are much bigger than the left main. It's calcified. So you can see calcium before you inject. And then the right, obviously, you can see is an eccentric lesion, big right dominant system, and it's tight. So we decided in her case, she was referred from an outside hospital. Her LV function is normal. So we decided to do imaging on the right, just to make sure that, see what kind of plaque it is, see what we need to do, because it's very calcified artery. We're starting from the top to the mid portion, and then distally it looks pretty well spared. So we did imaging first, and I'm going to show you guys.
Jazz, can I just ask you and Howard a question? So you've got left main disease and contralateral right coronary artery disease. How do you guys make a decision? We actually, John LaSalle and I talked just yesterday. How do you make a decision? Am I going to tackle the left main first, or am I going to tackle the right first? So how do you guys, is there an internal algorithm that you guys use to say one or the other?
What do you think, Howard?
They're speechless.
We're going to do the simple first.
I like to try to do the one that's most likely symptomatic, and that's hard to know without physiology. But I think you don't want to send this patient, have a complication that delays treatment of the symptomatic lesion, and then have the patient waiting days or weeks to come back for another procedure. So
You do the culprit first, I believe, and then the rest is what you can do. Obviously, things have to go well with the culprit first before you move on to the second.
The problem here is, like Aaron said, the problem here is you don't know what the culprit is.
Yeah, exactly.
You really don't know what the culprit is. She's having angina and she's got symptoms. The right looks tight and the left main. So, the reason why we chose the right first was because the left sided is complicated. And you know what? We may get into, in terms of complications, radiation, in terms of all these things, bifurcation. We don't know what's happening with the left main. So we thought, if we can fix the right, it looks relatively focal, but there's proximal disease. We fix the right, then we go and spend our time to do the
So let me go back to the conversation John and I had yesterday, and if John's on the panel, maybe he can comment. The tenet of the early left main intervention days, and that's dark ages by now, 2012. But the early philosophy was based on observational and registry data, that if you did the contralateral right first, there was an advantage. There's actually, in some of the studies, a mortality benefit of doing the right first. Now, I don't know in the modern era if that holds true, but John, what do you think?
Yeah, I think in those situations, of course, there were suspected collaterals coming off the right that would support the left. And we didn't have the definitive treatments we have now with excellent stents and bifurcation techniques. So we needed all the support we could get. We obviously didn't have support devices other than a balloon pump. And so you were just basically trying to bolster your chances of having success on the left and not having a hemodynamic collapse.
So in other words, that may be an antiquated philosophy based on modern technique, modern devices, et cetera.
It could be, but it was valid, certainly valid back then.
The other thing is, two things you want to separate is acute coronary syndrome and stable angina. The stable angina, these people are preconditioned. So, the left main ostial LAD is tight, the right looks like it's tight, but LV function is normal. It's stable angina is not troponin leak or nothing. So those are two different scenarios. So if it was troponin leak and stuff, you figure out the culprit, then you need to worry about the support here because, if your left main was eccentric and ostial LAD, whatever, they had troponin leak, then you put a wire through there, patients are not preconditioned, they crump. So you need hemodynamic support. Here, patient is stable angina, no troponin leak, they are preconditioned, and LV function is normal. Then you think about, listen, hemodynamic support may not be needed here. But listen, those are the things that, sometimes it comes to comfort, sometimes it is. So the rationale is preconditioning versus no preconditioning. Sure. We had a patient that we thought LV function was normal, left main looked a little hazy here and there. As soon as we wired into the circumflex, patient crumped right away because that was no preconditioning, even though LV function. So those people, they need hemodynamic support. Here, I think we can get away, without hemodynamic support. So we're gonna do the right. We're gonna do the right, have some protection theoretically, like David said, and then we'll go from there. So let's get going, guys. Here, I'm gonna go over what we did here. So this is your right injection, and you can see calcium. And so we decided that really, when you have calcium like this, we want to image this. So we did IVUS. You guys can see the IVUS going in there, and we can see the IVUS when it comes in there. You can see there's about 180 degrees of superficial calcium, and then when you come proximally, there is significant narrowing proximally also. And we didn't appreciate that, but on IVUS, it looks like very significant narrowing, no disease distally, and then you can see when we measured the area here, if I can stop this,
Yeah, must be for
And
sure under
open-
4. It was very small, the area there, under 4, because the
Yes.
diameter, the MLD was 1.5 at one area. There was a very important IVUS that Jazz showed us.
can you go live on Iris? Yes, so can you go, Iris? Yes, so if you see now, I'm measuring it's 3.6 distally, then you come back, George is right, you can see now, you come back, that's our
Right,
dye injection, we wanted to make sure that's the branch. And you see now, you have attenuation artifact right here at the back, right here. And then you see 180 degrees of calcium. The area is small, and proximally when it comes, it jumps through the calcium. So if I were to measure here, if you see here, if you measure it, it comes to, there's areas where it comes to 6.1. And, and then you come
But
back.
that's not the
and
tightest.
see
The
we'll come
tightest
back.
jumped a little bit before. The tightest was before, was about half that.
Yes, you're right. So I'll show you. Look, we come back, it jumps right there.
Yeah,
Right
even
here.
right in
before.
there, yeah.
Yeah.
Right there.
There you're kind of
The dots here,
You're kind of stuffing the catheter, so you
Yeah.
know that's going to be fairly significant.
right. So it's 3.8,
That's
it's
it.
like
Yeah.
close to
But Jazz,
3.8
this
or
is-
even more,
this is still an-
sometimes that.
This
So
is
what
still
we
an
did
this is still an
because
anatomical
academically-
assessment that's supposed to translate into
Academically, we
physiology, but we have
put,
physiologic tools to use, and we want to alleviate angina. Why aren't we doing physiology?
No, that's exactly what we did.
Oh,
So we
good.
did physiology.
We're
We
gonna do
did
both.
physiology because we actually, when we looked at it, we thought it was 80 to 90%, okay?
Yeah.
So we IVUSed it, we planned on treating it because patient is symptomatic, angiographically, it looked very tight. When we did IVUS was only done in this purpose to figure out what modality we're gonna choose here. This
Gotcha.
calcium, we're gonna figure it out.
Yeah.
Then when we looked at the thing, we said it's eccentric, maybe the lumen may be adequate. It's 3.8, 3.5, and 5 points, so whatever area you cut it. So we did physiology. So show the physiology, guys. You guys ask good questions, and we do it for you guys. That's what
Well, I
we
just
do.
wanted the audience to be
So-
clear, this is anatomy. This tells you
Yes.
whether or not to pre-treat
Right.
and prep the lesion.
Absolutely.
How big the vessel
Absolutely.
is. This doesn't tell you whether or not to intervene. I knew you would do physiology.
Right.
That's why I asked the question.
Yeah, and so as
Absolutely.
the only time we would ever take into consideration the anatomy might be a left main.
0.7.
Right.
I mean, this
Look
is
at this. Can you guys go to physiology, please? Look
Yeah.
at this.
Hey, I
So
think
you
that-
see here,
I think that's
there's two
significant.
things. One, you see the diastolic gradient, and you see a huge systolic gradient. So, as you know, the right coronary artery has both systolic and diastolic flow. And you'll see here, there's a huge systolic gradient. And that you see mainly in the osteal rights, sometimes when you have systolic gradient like this. But IFR still is 0.72, markedly ischemic. You see that? So area sometimes is not reliable. Here, we're opposite. Here, physiology tells the answer,
Hey, Jazz?
not imaging. So, yes, sir.
Jazz, if you saw this initially, let's say you weren't suspecting the lesion was going to be this tight, would you think that maybe I've got an artifact because it's so pronounced, like the coronary catheter is stuffed into the right coronary ostium?
Yes, absolutely, John. So that was the key. So when you do physiology in this setting, you want to disengage, you want to normalize in the aorta. Then we put 2 wires down so that we can pull the guide out of the ostium. We did that, and that's exactly what we did. And you can see, on the screen, if they can show you, we put 2 wires so that we actually pull the guide back, because if you had 1 wire, you pull the guide back on the right, it pops out a lot of times. So you put 2 wires down, we made sure we disengage the guide, and you can see the pressure is dampened. The yellow one and the red one is, look at a very nice dicrotic notch with no dampening. So those are the waveforms you want to see. So when you see that, then you know it's absolutely correct physiology. So
this
that's
is-
a very good question, John. I mean, I think
this
test
is-
is test,
I
but
wanted you to
doing it
show-
right is very, very important.
Yeah, I wanted to show off your technique here because this is a key component. I mean, there are a lot of different ways you can get positive FFRs or IFRs if you're not meticulous. I mean, we used to have a saying that, if you want this one positive, I can make it for you. But you want to troubleshoot, you want to make sure that you're normalized, you're not engaged with the catheter. And because we're going to move the catheter in and out, we might lose that position. The second wire will help you with this. So this is a nice little trick to overcome those problems.
So if you look at the screen now, you see we did IFR, so at 7.0 distally, we pulled back, and you see this co-registration, it told us that that lesion that we saw was critical. It jumped significantly. And then you saw a gradual rise in the proximal area also with dots. That tells you that the proximal area is also diseased. So you can actually play with that co-registration screen and tell you go distal and come back and see how much gain you're gonna get and what length of stent you need to get a good gain. So pretty impressive co-registration. Obviously, it's a no-brainer. Listen, physiology wanted to do, but you see, it told us that that lesion is indeed very, very significant.
So Jazz, now that we've got physiology, now that we've got invasive anatomy, so we know we want to fix it, to Aaron's point. Now, how do you decide? So there's a bunch of different plaque modification methodologies, from simple balloon to shockwave to roto. So how do you decide now which of these you're going to use?
Well, so if you look, our imaging that was the whole purpose of the imaging when we did initially to do. So I'm gonna roll through imaging, guys. Can you go to the IVUS screen, guys? And so if you can go to the IVUS screen, yes, perfect. Yeah, so if you see now, that's the RV marginal coming in there, and then you have 180 degrees of calcium right there, very, very tight. Calcium is actually more than 180 and very thick calcium. So if you see the thickness right here is a lot of thickness, and the length of calcium also is large. So length, thickness, and the circumferential stuff, it is probably more than 180 with thick calcium, more than 5 millimeter length. You can see that these are the ones that usually don't yield. And if you do atherectomy, so you do rotational atherectomy here, you have a decent lumen, but it's very, very eccentric. So you need a bigger lumen, and then you run the risk of, depending on what your bias looks like, you will go here, and you have issues in this, unless it was big superficial calcification and you take a 1.5 burr and break it. This one, I think two things will work here. Either orbital atherectomy will probably work, but you obviously, this size is differential, this side is calcium. And the other thing we thought in this setting, because it's thick, it's deep, and it's not that tight, I thought shockwave would have a very, very good use in here. So that's what we decided. We decided to do shockwave therapy in here. But I think orbital would work here. I think rotational, not so much, depending on what the imaging shows. So each one of them has a different role, but I think we decided on orbital. What do you think, David? What do you think?
You decided on
shockwave, yes.
Yeah, I think shockwave's a great choice.
So this is, guys, this is an excellent differential on how to go through these calcified lesions. First, in identifying and how much was there, what the circumferential degrees arc of calcium is, and then what one do you choose? It's not high-grade calcium. It's not long rotoblader, not going to get you so much bang for your buck. Orbital will certainly do it, and because it'll swing around and hit that plaque. However, I will say in the defensive rotoblader, if you had a favorable wire bias, that might put you into that plaque a lot easier. But you have a reasonable lumen, so that it's calcified. You got a reasonable lumen, and shockwave's going to fit right in there.
Yeah, what size shockwave you used?
When you did the shockwave?
What size is the shockwave you used?
So you want the shockwave to really approximate the size of the vessel for it to work best. So we got a very precise measurement, about 3.6. So we chose the 3.5 shockwave, and despite the calcification towards Rossi, you could see it tracked extremely well. I was a little surprised.
Yeah, so you can see that the screen, it actually delivers, on the fluorogram, it delivers very, very nicely. A 3.5 balloon went through the eccentric calcification very, very nicely. And then what we did is we inflated it up. We have to get going to the left side here, guys. So I'm gonna go over this. So you see balloon inflated at 4 atmospheres. We give 10 pulses, 1 per second. We did that and then stopped, did another one, pulled back and did another one. And then we went down and inflated it to 6 atmospheres just to make sure, when we did it on stent boost, to make sure the balloon was completely yielded, and it yielded beautifully. It really did. So where we are right now, is I'm gonna show you right after the shock wave, we did both areas here. You can see there's a waist proximally. You see that? That area we didn't even, the main lesion didn't have that much of the lesion, but you have a waist proximally that we saw on IVUS that we really did not appreciate. So then you can see you see right there, and then after that it yielded. You'll see
So we had
this
made this
bubble
point.
there, and it yielded, yeah.
So we had made this point
So-
earlier, Jazz, in your lecture that, you know, you get 80 pulses, you know,
Right.
It'll turn out great.
8 per 10-second run there. You might as well take advantage of it. If you see calcium proximal or distal and you can deliver it there, go ahead and take advantage of it and use it. Similarly, as far as the trackability of the balloon, many people say it's equivalent to like an angioscope, so not like a regular your regular balloon, but something like a specialty balloon. So if you're trying to gauge whether it's going to deliver well or not, think about it along those lines.
So I'm gonna show you our distal area. This is post shockwave IVUS. You know, the vessel is 3.5, 3.6 distally. And you see, look at the calcium before and look at the calcium now. You see this broken up calcium right here? Remember it was thick. Remember when I measured the thickness? You see what happened? There's cracks. You see this area? It looks very different than OCT would actually probably delineate better, but you can see that that calcium is broken up. It wasn't like that, remember? It was a straight here. This calcium is broken, and it's actually pretty impressive. So you can see here, that's the proximal area, and that area we did not appreciate proximally, but you can see there's cracks in the vessel rather than a uniform superficial calcium that you see. Even on IVUS, you can see that. OCT would show you this better, but I'll tell you, this is actually pretty impressive finding here after we did 3.5 shockwave. So what we're gonna do now is did you guys,
Get a stent in there.
yeah, what stent you choose? Yeah. So,
3.5 horsepower.
yeah, 3.5. So we measured, we had a 3.5, so we can go a little bit higher, this 3.7 distally. So we took a 3.5 stent. We chose Osiro here because I think just because of length and diameter, it grows a little bit more. Listen, in this case, I think it's a 3.5 vessel. Megatron would be amazing here. Resolute would be amazing here. I think any stent would do very, very well here. The key is 3.5 vessel. You get good lesion prep, and you put a stent in there, you're gonna do great. We are choosing it just because of length and little bit growing balloon material. So this grows a little bit more than the other stents. So if you put a 3.5, we can make it 3.8, 3.7 with balloon inflation, and we'll see how this yields. And that's the reason. That's the reason for the choice. But here you can use any stent.
So George, John, someone on the panel, for those in the audience who may not have used shockwave or is just hearing about it, obviously it's the technology we use for blasting kidney stones, if you will. You want to talk about the balloon lithotripsy device and how it functions, how it works?
Yeah, come back.
Flip back your guide, Prashant.
Get your guide back and
We had a beautiful lecture this morning. You know, these are sonic waves, essentially. This distribution is you get
It's fine.
10 pulses,
look at
and in
that.
this balloon, you can do that 8
Yeah,
times.
push the balloon.
In between those 10 pulses, you let the balloon down,
Yeah, that's
and let
perfect.
things cool off a little bit,
Yeah, right,
reperfuse
yeah.
the distal
that's
vasculature,
good.
and then go back up as needed. And as I said before, I like to use all of them, even in areas that I may not have initially wanted to use it in, as I see that there's more calcium, like on my IVUS, so I can get as much out of it as I possibly can. Now, I've used the
You see, guys,
I've used the number 50 a
John,
couple times.
you see how the stent is going up?
Yep.
Look at that. Look at that. We didn't even, pre-dilate after the shockwave. You see how the stent is expanded? Looks beautiful in terms of the distal area. That proximal area that we didn't even know there was a lesion is still a little resistant, and there's a little waste in there, but we're gonna hit that. But distal area that we thought was the culprit, look at that. Look at how he yielded without pre-dilatation. In general, you should do pre-dilatation, but in terms of after shockwave, you can do a non-compliant balloon to make sure those cracks are there, but you wanna get a luminal gain before you deploy the stent. But in this case, we IVUSed it, we know it was cracked. We took a stent just to see how this thing is gonna go, and it worked out pretty nicely. You got very bradycardic, very symptomatic with the stent deployment. You can see, if you show the hemodynamics, guys, she really became very, very bradycardic. Now she's coming back. Pressure is coming back. So this is a big right, probably culprit in terms of IFR of 0.72.
So Jazz, this is
very, very
managed
significant.
while you're working.
So go ahead and give vasodilators. Vasodilators.
So
and then
Jazz, this
take a
really
picture, guys, and then we'll
demonstrates
have it.
for the audience, this is a calcified nodule, which looked innocent, but what you really showed with the imaging and physiology is that not only was the index lesion in the mid-tight, but the
Yeah,
prox lesion needed to be treated. And you might have gotten away with a non-compliant balloon, but don't be surprised if you didn't, with a gross underexpansion. And I think this is really where the technology of imaging becomes critical with respect to prepping the vessel. My question for those out there that may not have access yet to IVL. So Aaron, a cutting balloon here or something else if you don't have
Picture first or
IVL?
just post it. Picture first or post it.
First of all, there was only 180 degrees of calcification. And so the whole question of which technology to use is a valid question, whether or not you would modify it in the first place.
Right.
I think is a reasonable question. Which one to use, if you've decided on it and you're committed to it, you use what you have access to. I would be have used IVL in this particular instance. And if for some reason the balloon wouldn't cross it or some other issue and I couldn't use it, then I would have used rotational atherectomy and hoped that the wire bias didn't lead me away from this. I think it's really important that you image afterwards. The concern I have with nodular calcium like this is less so about stent expansion and more about that spicule of calcium blowing out the back wall of the artery when you do your post-dilation on the stent. And having seen it fracture gives me great comfort that he's going to be able to aggressively post-dilate this stent without that happening.
I mean,
So
I was surprised
we are
that
taking the thing and
I was surprised that the imaging was so impressive in the proximal lesion. I wouldn't have think so. I wouldn't have thought so. But regardless, my choice here might have been just a 175 burr, so that always takes care of the proximal lesion also on the way in. So, but
Yes, so-
it was interesting.
Let's look at this. So is it distal? Distal is 3.5. We did imaging, beautiful distal branch. You can see the primary lesion is still elliptical. Still, look at that. It's still resistant in terms of stent. So you don't image these. We can measure the minimal stent area here. It is not 80 to 90% of the distal reference area. Okay,
Jazz.
guys, this is where TLR happens.
Tim Fischel. So
Yes,
the IVL does not remove the calcium. It disrupts it, and it's especially useful if there's concentric calcium for sure. When you have eccentric calcium like this, and clearly this boulder on the one side of the vessel is preventing full stent expansion, do you have IVL regret here? Should you have drilled this and removed some of the calcium to get better stent expansion? I mean, it was a good, reasonable thought process went into it, but in retrospect, with that stent expansion, would rotoblator or CSI even been better?
Yeah, like we talked about, like John said, if the wire bias is favorable, rotational atherectomy will work here, okay? But if it's not, the lesion was not that tight, you probably might not get enough purchase. So unless you image. So imaging told us. So I thought CSI would work here, I know, in terms of the things that need to break it. This broke the calcium. And now we didn't pre-dilate after that. We cracked it, but the stent, obviously the stent balloon is not as strong. So what we want to do now is we're going to post-dilate and we see whether we get an, concentric, eccentricity index, the diameter this way versus this way, is more than 0.8. That's what we want to target. So we want to make sure that it did something for us. And our sizing was amazing with the balloon. Sometimes you undersize with IVL, you really don't achieve what you need to achieve. So that was not the case here. So we want to make sure now that when we post-dilate, we want to make sure that we actually improve that. So what was the minimal stent area, guys?
6.1.
6.1. And then can you guys measure the distal reference area? And then, so the way you know what your minimal stent area should be, people talk about 5.5, but this vessel is bigger. 5.5 may be small in this setting. So what do you want to do is you want to make sure that you get close to 90% of the distal reference area.
So Jazz, just
so
an
I'm gonna do
update,
stent-
just an update time-wise, we have about, at least on the schedule, another 5 minutes.
Oh, you do? Okay, perfect. Yeah. So you can see now, I don't know if it projects on the stent boost and stuff, if they can show you, but we can see that the stent is not expanded on our stent boost screen. It is not expanded at all. So we are now going with a balloon, 3.5 balloon, and we're gonna crack that 20 atmospheres.
So Jess, I didn't see, how many pulses did you deliver to that lesion?
We actually delivered 70. So we did probably 30 in the distal area.
Okay, 30 on that particular
30
spot.
to the distal area, and then proximally we did 40. So we did 70.
And I think that's one minor point to make, that if you don't have a 270-degree arc of
3.5.
calcification, you got to do a lot of
We
pulses.
had 3.5 by 15 NC.
When you're less than 270. So he gave 3 sessions,
Yeah, there's, again, Jazz showed the data, the complication rate is very, very low with this. I don't think you lose a lot by putting more into it.
Yeah.
And, that number I keep sticking out in my mind is that what does the sonic impulse produce? What is it equivalent to? It's like when you set off a nuclear explosion, they keep measuring in dynamite, what dynamite is equal to. And so in a sonic burst, it's like 50 atmospheres. We don't have anything that does 50 atmospheres.
So let me ask somebody on the panel, hypothetically, if you IVUS this again and you're still not expanded, would you go as far as putting another IVL balloon in and doing some post-stent IVL to see if you might be able to get some energy past the stent struts into the lesion?
So it's a great point, Aaron, because, it doesn't matter whether it's pre or post, this thing still works. I have a great case I showed yesterday of a 18-year-old in-stent restenosis. That's some of the hardest non-calcified tissue you'll ever see. We did laser with 50-50 contrast, created a channel, and then went down and did IVL. And what was interesting is not only did it open up, but there were dissection planes outside of the stent. You could see the dissection planes. Now, that might be somewhat disconcerting, but to me it means that we fractured outside of the stent. Created a portion of the vessel itself that could now expand further. And by putting it was followed up with a Megatron, it actually compressed everything out and it opened up the lumen even greater. So there's a possibility of not only affecting calcium superficial, but also deep areas of fibrotic tissue outside of the stent.
One other quick comment. I mean, the Osiro is very deliverable. It has the thinnest struts. People love that. But hoop strength, radial's hoop strength is the square of strut thickness. So this is about a 2.6 thousand strut thickness stent. Zions is like 3.2, 3.4 thousand. So you chose a stent that doesn't have much radial hoop strength.
I would agree. My personal preference for something like this would be to take a little more hoop strength.
Yeah, if you look at the proximal area, it looks like nothing was done proximally. The stent is very underexpanded proximally. This area yields beautifully. So proximal, we're going to post-dilate. I agree with that. Listen, I think we are learning as to what, Aaron's, comments on if you do another shock wave in there. The problem is you don't know really what it does to the polymer and the drug in terms of what it do pulverize the sonic wave. So it may cause more deformation of those things so that you get restenosis. So I don't know. I don't think there's enough data to say that, but I really think it will probably do harm to a newly implanted stent if you do that.
Yeah, that's a great point, Jazz. I should have made.
And your balloon is fully inflated. I don't think you have a lot of problem with yield here. You have a problem with recoil.
Recoil. Yeah.
Yes, absolutely. I agree with that. I think we broke the calcium. We did the stuff. I think these balloons, because of that nodule and stuff, these balloons keep on rupturing. So Howard is aggressive with the balloon. They ruptured. 2 balloons actually ruptured here, guys. I didn't tell you guys. 2 balloons actually ruptured. So we're going to get a strong balloon. Can you guys get me that 3.5?
I'm going to go a little bit higher, 3.75.
Yeah, get a 375 approximately.
Yeah.
Let's get a little bit bigger balloon and make sure we get good luminal gain and we'll IVUS it. And I think we're gonna be okay.
I think it's
And I'm gonna
appropriate
do
to
a
point
stent.
out that, we've gotten to the point where we almost think we've commoditized stents. But there are still some differentiating features. Absolutely. Tim, you mentioned the Svelte stent, right? That's the thinnest strut stent that we potentially will see in the next few years. But this might not be a good application.
Let's take a
for it.
picture.
If you want deliverability, absolutely. But if you want something that provides more radial strength, you would
Yeah, I
definitely do
mean,
something else.
the old stents, BX Velocity, Cypher got a lot of bad heat, but it was 5,500 wall thickness. I mean, it would hold an ostial open. There was no recoil. So, somewhere between 5.5 and 2.6 might be the right for this lesion.
Yeah, I think in retrospect, I think the stents we have now, I think Cypher would have been great. The stents we have right now for these calcium, my fellows gave a talk, what stent to use. And, the guide actually popped out. So, what we need to do is we need to figure out, I think Megatron and the bigger Resolutes are actually much better stents in this setting than I think the recoil with the stent struts and stuff. You're right. I think that's an issue. So
Yeah,
let's take a picture, guys.
when we say recoil, just to give you a percentage, we're not talking about, 20, 25% recoil. We're talking more in the range of something less than 10%, but it can still show up like this.
Yeah,
So
angiographically,
this
that looks pretty
lesion looks
good.
great. The proximal area still is, I think, not that expanded in our balloon rupture. So we're gonna do a little balloon inflation here, guys, and then we'll quickly IVUS it so that you guys can see it, and then we'll go from there. So listen, we have to do the left main LAD and stuff. So, when you guys are ready, you guys can leave us. And then what I'll do is we'll do our case. And then Nicholas, when you guys have time, come back and we'll show you how we approach the left main LAD, ostium imaging and physiology, and then what modality we use. And then we're going to keep on walking and get through. So John, let me know whenever you guys are ready, and then we'll keep on walking here.
Great job, guys. Jazz, excellent explanation as to your approach to these type of lesions. And I think the panel discussion was extremely important.